underway, if the members could briefly introduce themselves, starting with, oh yeah, Pledge of Allegiance first. That's right, Representative Rigby. Just making sure you're on your game, buddy. You could lead us in the pledge.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
All right. The members could briefly introduce themselves, starting with Representative Gregory.
We go. Hey, good morning, everybody. Representative Jim Gregory, representing the 80th District, serve on the Human Services Committee, previously served on the Opioid Board of Trustees as well. Thank you.
Hello, Representative Eric Nelson, Westmoreland County.
Good morning, Ann Flood, 138th District in Northampton County.
Josh Kale, Beaver, Washington Counties.
State Representative Doyle Heffley, 122nd District, Carbon County. I also chair the Human Service Committee for the Republican Caucus.
Good morning, Jim Rigby, 71st District, Cambria, Somerset Counties.
And I'm John Schlegel, representing the 101st District in the heart of Lebanon County. I'm also a member of the Human Service Committee.
Brad Roy, the 6th District, parts of Crawford and parts of Erie counties.
All right, and we do have members joining us online. Representative Kristen Marcel is online with us. There will be members coming in and out as we go. There's activities happening today. We appreciate your patience with us. Chairman Doyle, thank you for leading on this very important issue. I'm looking forward to the conversation and discussion that we're going to have here today. If you'd like to give some brief opening remarks, the floor is yours.
Thank you, Chairman Kale, and I want to thank you and your staff, the policy committee here, for organizing this hearing and putting all the testifiers together, Leah, Dan, and also Anne Marie, Executive Director of our Human Service Committee here, for contacting this really kind of a diverse group, but really a group that is going to focus on all the different trends that are out there, some of the things that are working, and give us a different perspective and insight as to what we're seeing. When I first came into office, probably the last thing that I campaigned on or talked about was the opioid crisis and drug overdoses. And while we did a lot of work on the opioid task force, there's still a lot of work to be done as we see the new trending drugs, and really trying to, I think at this point, we need to continue to work on those solutions and help those people in need, while we also look forward to what's going to be happening in the years coming up. So I thank all the testifiers for being here, giving up their time, and all the members for coming out today for this, what is probably the number one, I've always felt to be one of the number one health crises in our state. In, I think, 2023 numbers were revised. I think about 4,700 individuals lost their lives to overdoses, and I think about 80% of that was somehow linked to fentanyl. So while those numbers have come down, it's still 4,700 families that lost a loved one. I personally know families that lost children, and brothers, and I also know folks that are living a life of recovery now. So I think it's important that we focus on every aspect of this crisis as we move forward. And I thank you, Chairman Kale, for bringing this subject to light.
Thank you, Chairman. This is one of those issues in Harrisburg that touches every corner of the state, every different demographic, every subset of the state, subculture of the state. I know for me personally, within my district, the first time I really encountered it as an elected official was when I was knocking on doors, talking to constituents, and I met a lady who was in her mid-60s, and she had a bunch of small children running around the house. And she went on to tell me that her daughter died of a drug overdose, and her son-in-law also died of a drug overdose, and she was there raising her grandchildren because of it. This impacts everybody across the board, and thankfully it is one of those issues that I think there is a lot of people on both sides of the aisle that want to come together and solve the problem. There's differences of opinions on how to best do that, but that's what we're here to do today, is to figure out the best ways moving forward so we can help and serve our constituents as it relates to this epidemic. So today we have a great panel. We have 4 testifiers. One of them is not here yet. She is on her way. She will be here. She is parking. Our first testifier is Dr. Michael Lynch. He is the attending emergency physician and medical toxicologist at UPMC. We have Judge Stephen O'Neill. He's the presiding judge of Drug Treatment Court in Montgomery County. We have Chris Pawlowski, the chief probation and parole and pretrial officer at Chester County. And we have Jessica Miraglia. And she is not here yet. She is the Assistant DA of Luzerne County. When Ms. Miraglia comes, I'll make sure that she knows that she will be testifying in a couple of minutes. But Dr. Lynch, thank you for being here. If you'd like to begin, we like to keep testimony between 3 and 5 minutes. If you go over, you're not going to get gavelled out. It's just we like to make sure we have a robust Q&A as well. So, Dr. Lynch, the floor is yours.
Chairman Kale, Chairman Heffley, distinguished members of the committee, I appreciate the opportunity to talk to you today. I was asked to give a high-level overview, I think, of trends of what we're seeing with drug use across the Commonwealth. As Representative Heffley mentioned, approximately 4,700 people died last year, which was actually down 9% from the year before, but yet still far too high. So typically when we're talking about national and Pennsylvania trends, we think it's often described in waves: prescription opioids, then heroin, followed by fentanyl, essentially overtaking heroin and replacing it, and now the addition of stimulants to fentanyl. So that fourth wave is not really moving from fentanyl to stimulants, it's adding stimulants like methamphetamine, cocaine, and others that are illicitly manufactured to fentanyl. So approximately 83% of overdoses last year were related to opioids, and about 77% of them were related to fentanyl. So that still is driving the overdose death epidemic, but what we've also seen since 2017 is a 50% increase in the number of overdose deaths where stimulants were also involved, and that accounts for almost half of all overdose deaths, and actually a doubling of the number of overdose deaths that were only from stimulants, which accounts for a little over 10% of overdose deaths. So that has been a trend that I've seen clinically working in the emergency department, but we've also seen in the data. A trend that we're following as well is xylazine, of course. So in 2017, we had no reports of overdose deaths with xylazine present. Last year, about a quarter of overdose deaths had xylazine. And certainly that started in Philadelphia and the surrounding counties in 2018 and has moved sort of westward and northward such that it's essentially everywhere in the Commonwealth. And while it was reported in 47 counties last year, I suspect it was present elsewhere as well and potentially not identified. And so what is xylazine? Xylazine is similar to pharmaceutical agents. The way it works in the brain essentially is it causes sedation, lower heart rate and blood pressure. A contribution in combination with an opioid may increase the degree that you slow down your respiratory rate, which is how people die in an opioid overdose. I will say, though, there are conflicting data on whether the presence of xylazine actually makes it more likely people die from an overdose, because in some cases they found that there's actually less fentanyl because the xylazine is present. Regardless, it has caused significant public health impact, both through its presence, contribution to overdose, as well as withdrawal, which can complicate getting people into treatment, and significant wounds, which I'm sure we've all heard about, which are not only disfiguring, but can lead to severe infections, require increased hospital healthcare utilization, surgeries, amputations, so a significant impact. More recently, we've seen a similar drug called medetomidine, and there's a medication that we use in the hospital called dexmedetomidine, which is a chemical relative, and we have yet to see whether that has the same association with wounds, but acts about the same way in an overdose. As far as fentanyl, some major trends that we're following are its presence in pills. So fentanyl pressed to look like pills, like a prescription opioid or even a prescription benzodiazepine or non-opioid drug, which is particularly dangerous if people don't know they're taking an opioid and don't have the tolerance. So DEA reported in 2023 that they had a 10 times increase in the number of seized pills that had fentanyl compared to 2021, and I think it was more than 2,000 times what they had seen in 2017. So that has exploded, and we see that clinically. I talk to patients frequently who took pills to avoid fentanyl, only to overdose on fentanyl because it was present in those pills that they purchased illicitly. Another trend that we're following are a drug class, 2-benzodiazepinedazoles, or nitazines, is typically how you'll see them referred to. Nitazines are a completely different structure than fentanyl. They don't test the same in our drug tests, and we don't have drug tests typically that find them outside of sort of reference laboratories. And those are similar to potentially slightly more potent than fentanyl. They're not as potent as some of the more potent fentanyl analogs like carfentanil or methylfentanyl, but the effect can also last longer, which could potentially be seen as a benefit, because one of the things that people who use drugs don't like about fentanyl is a rapid up and down, which is probably why xylazine grew in prevalence, is because it prolongs some of the effect. So we continue to follow that. We know it's been present. Philadelphia has reported it. We've seen it in other surveillance systems, though the actual prevalence is hard to know. But we'll continue to monitor. For now, with xylazine, the nitazines, and other drugs, typical naloxone doses continue to work, and we continue to emphasize naloxone availability anywhere and everywhere in the community to reverse those overdoses when they may occur. And then as far as trends that we've seen recently, that, we saw a 9% from 2022 to 2023 in Pennsylvania reduction. CDC last week released more data showing about a 10% reduction in the 12-month period ending in April across the country, and actually an 18% reduction in Pennsylvania in that time frame. Obviously, we'll see if those data hold true as we gather more data. I'm hesitant to be overly optimistic because we've seen that kind of trend before, and we've seen it reverse again. So we're always on guard for that. But I think what's important is to really highlight the work of so many, the legislature, departments, drug and alcohol programs, health, human services, healthcare providers, and other stakeholders, recovery support services across the Commonwealth that may have contributed to that. I think making sure naloxone's available. As you know, the legislature approved testing kits, which I think is really important because of the presence of xylazine as well as fentanyl and non-opioid products, to know when they're there. There's data that show that that changes how people use them. Access to treatment is critically important, particularly in underserved communities, thinking of rural communities where access to treatment providers is harder. It's harder to get there. They're further away. People leaving jail are 10 times more likely to die of an overdose than people who weren't in jail. And then we've seen a significant divergence in racial disparity, with Black Pennsylvanians more than twice as likely to die than white Pennsylvanians from an overdose as far as rates. So continued emphasis and focus on those kinds of projects, I think, will be, from a healthcare perspective, critically important to continuing that downward trend. And otherwise, we'll continue to follow. There's typical classes of drugs. They're always changing, as we know. When we try to schedule one, there's another. The term whack-a-mole is said a lot, and that's for a good reason, because it's true. But we'll continue to monitor on the medical side and work with our law enforcement, legislative, and courts and other stakeholders to make sure that we follow and address those concerns. So I'll conclude there, knowing that we have a lot of really good testimony coming up, but I'm happy to take questions now or later. Thank you.
Thank you. Judge?
Thank you very much, Chairman Creel. I just think having this hearing is important. Any time that people who are in positions of authority, positions that people look up to, have hearings on crises such as this, it's a statement. It's a statement saying, look, we don't know what we can do. We don't know where the money's going to be available, but it's a statement we care. And I think that that's, why I do treatment courts. It's why the treatment court movement in this country is the most successful intervention in terms of, crime in Pennsylvania, because most crime is driven by a substance use disorder. My background is that I've been a judge for 22 years, having taken the bench in 2002, and quickly saw what the impact is of substance use disorders. And you'll hear me, I'll use them interchangeably: addiction, substance use disorders, as we try to change some of the nomenclature around it and less stigmatization of a disorder, of a brain disorder. I mean, that's what it is. And for some reason in this country, we treat it far different than we do other disorders that we have research money to treat. So I quickly saw that that there were many people just kept returning in front of me. And what did they have as a common denominator? What was their common factor? And I quickly discovered that in our correctional facility, and of the crimes that are charged, about 75%, 75 to 80% of the people that are in our correctional facilities have a substance use disorder. So if we looked at it and say, well, incarceration is a way, It's a failed way. It doesn't work. It costs far more money than it does to treat those that are in our prisons or those that are about to go to our prisons. I started to look around for another way. I don't come this where I'm a man of recovery, or have I lost loved ones to disease. I was more pragmatic to think, follow the evidence, follow what may be working, because I just don't believe, doing things as a judge the way they used to be done works anymore, quite frankly. So I set about studying these treatment courts. I saw that there was, at that stage, maybe about 1,000, maybe 900 or 800 of them in the country. They started in 1989, of all places, in Florida, Miami-Dade in Florida, where they had a cocaine problem back then. And there's plenty of cocaine coming in, but plenty of people using it. And there was a judge down there who felt that, hey, would we be better off treating these people as opposed to incarcerating them away? We have learned long ago that you just can't incarcerate away, a brain disorder, one that is going to get back out there, and unless you're treating the underlying issues, you're going to have the problem. So I studied it, and fortunately I come from a county that had some enlightened stakeholders, county commissioners, and I went with a proposal, and they funded it. And I've been running a treatment court there for the last 18, 19 years. We are a large treatment court. We are one of among 4,000 of them in this country. It is a movement that grows only for one reason. It works. It works, and it is far cheaper than incarcerating individuals for the crimes that they commit, which are really symptomatic. There are two major symptomatic issues with those who suffer an opioid use disorder: incarceration and death. And fentanyl has just clearly changed the game in terms of death. And that's why we have been dealing with the opioid overdose crisis. So for the last 18 years, it's a series of expanding the courts in Montgomery County, and they have expanded in Pennsylvania to treat we now in Pennsylvania call them problem-solving courts, of which treatment courts are a part of. There's 74 drug and alcohol treatment courts, pretty much in almost all of the counties across this Commonwealth. And they're there because they work. Clearly, my statistics, I have been around, and we track outcomes, and I think anything that calls itself an evidence-based practice, which is what a treatment court is, needs to know outcomes. What happens is we know that when people enter the justice system, when they have a substance use disorder, they return about 80% of the time, 75 to 80%. And if you can reduce that, then you're making a difference. You're making an impact. What we've seen, at least in Montgomery County, is that we've reduced that return down to about 30%. That's a major decrease. We look at the other things, the kinds that mean something to stakeholders, the number of drug-free babies that are born in, the number of parents that are able to be around in their child's lives. There are so many other holistic things that occur when somebody is able to control their substance use disorder. So these are numbers that aren't just, we've had over 850 graduates from our court, and they track. The national numbers are not as good as Montgomery County. I consider what we have is the reason we work so well is we have treatment. We have treatment. We have all levels of treatment that we can offer. Chris may talk, as to the functions of treatment court, and I'd be glad to answer any questions. But what we clearly know is of the 4,000 in this country that treat well over 150,000 seriously substance use disordered people in this country, they're not enough. Just the final comment on what we're seeing in terms of fentanyl, what happens is the overdoses were kind of replaced in the news by COVID. And that became the major medical issue in this country. But, from my perspective, the drops, we're seeing them. Why are we seeing a drop in there? Well, what has happened is we are responding in certain ways. We are responding with Narcan. We have made Narcan available in every community and every household in this Commonwealth, in this country. Well, if you have Narcan, you're necessarily going to see, because they can employ it before they end up either in the hospital or in the morgue. So you're going to see a drop there. What else you're seeing is that finally people understand that there is medication that can assist in the treatment. True recovery is long-term. It takes a long time, and that's why, as you'll hear, drug courts last 18 months, and it's 18 months of treatment, 18 months of recovery. That's why the success rate is high. We can treat it. Medication to assist treatment, MAT, what you all know is Suboxone or methadone or Vivitrol, which is, an opiate blocker, is the more you put that out into the community, together with long-term treatment, long-term therapeutic intervention, you're going to get these success rates. That's another reason you may be seeing some of these drops. We're putting it out there. The final part of it is we don't know, as the doctor said, that we don't know where these trends are going to go, but they may be two lending causes. There was a New York Times article yesterday, 60 Minutes did it, a whole piece on fentanyl. The crisis is not waning. As I'll close with simply saying, the tragedies, the sadness that is caused in the families across this Commonwealth. I know you still hear their voice on an individual basis because of how you represent your districts. But the problem is when we start talking about this, and I quote of a famous dictator, a horrible, horrible man, Joseph Stalin, but when we start talking about the death of one person is that individual tragedy, and you all hear it, and you all absorb it. But when we start talking about thousands and hundreds of thousands of deaths, you're talking statistics. And the problem is the individuals get lost. And the statistics, we're trying to make these, and we can never stop keeping, those people in this, who have lost sons, daughters, husbands, wives, and it is an equal opportunity killer. So I will take your questions. Thank you.
Mr. Pelosi.
Good morning, Representatives. Thank you for the opportunity to speak today. I don't want to go over what Judge O'Neill has already talked about, but I do want to talk about the typical problem-solving court programs that are run in Pennsylvania. So we have problem-solving courts, treatment courts in almost all of our counties in Pennsylvania. They're all a little differently, but they all operate very much similar. They are closely monitored by a judge, and that is one of the biggest things, when you talk about bang for your buck, the return on your investment is having that judicial oversight and having those individuals that enter the treatment courts coming before a judge on a regular basis and talking about what is going good for them and what is going not so good for them. So the judge leads the team and supports the agencies or supports the mission. In this team, you have a lot of other people that come to bat. You have representatives who are collaborative and they're coming together. The public defenders and the district attorneys, they're working together. They're not working against one another. They're working together for the betterment of everyone. We have law enforcement officers that are part of our treatment court teams, and this is a positive aspect. Today, law enforcement is not looked upon as one of the greatest things, unfortunately, but in your treatment courts, the law enforcement aspect and the law enforcement bringing them together as part of the team has a major impact that they can show the support of the individuals that they arrested. You have treatment providers, probation parole officers that are coming together and doing these things as a team approach. Generally, there's a very high level of supervision by the probation and parole officers, and they're bringing in those collaborative partners that come together in a case management style. Instead of a enforcement-oriented style, it is a case management style that we know that works. We tailor that with drug and alcohol treatment, and one of the most important things, random drug testing. Random drug testing that's done frequently. The individual calls in the morning at 6 o'clock. Between 6 and 9, they find out whether they have to test that day, and they have till 6:30 that night to provide a test. So there's no timing of when they can test, when they cannot test. Problem-solving courts are not only associated with the team atmosphere, they're associated with reducing recidivism, and the research suggests it saves taxpayers money. Why does it save taxpayers money? You have fewer arrests and less time in jail. As you all know, it's well over $100 a day to keep someone incarcerated. When you are having someone on the street in community supervision, you're talking pennies a day per person. for the Probation and Parole Department to supervise. When you look at the problem-solving courts, they follow 10 key components of treatment, of the treatment courts. And these were developed in 1997 by a bunch of judges that got together for the National Association of Drug Court Professionals. The 10 key components are the framework for the success of the treatment courts. The components relate to the team member makeup, eligibility, referral, treatment, monitoring, and community partnerships. Reentry is a big thing now, and it should be, and it should have been for years. But when you talk about reentry, you talk about community partnerships. And that has gone and been a part of treatment courts going back to 1997 when Philadelphia first started the first treatment court in Pennsylvania. You may ask, why are they effective? Practices that influence the success, again, as I talked about, is a collaborative approach, the team members. The biggest thing in my mind that makes treatment court successful is getting to the individual soon after they're arrested. It would be the best case scenario to have the treatment courts embedded into county pretrial services, which we do in Chester County. We have someone who works in our pretrial service department and is monitoring cases as they're arrested when they go for their initial arraignment, for their bail. They're offering the problem-solving courts. The benefit of that is that you get the individual quick and you can get them in the treatment. And when you can give someone interventions and treatment quickly, you're going to help them with their relapse, not to relapse, and you're going to help them with their recovery. Some of the things that we're seeing in the treatment courts as far as trends go is opiates are a problem. They always are, they always have been, and they always will be. But we're dealing with some new things now. We're coming back to cocaine. We're having a lot of individuals test positive, whether it be in treatment courts or on probation or parole. Methamphetamine is a big driver right now. I worked with a guy on Friday who came in, and you could tell he was not himself, and upon talking to him, he admitted to snorting methamphetamine the night before prior to him coming in. He was a former opiate addict, and he didn't want to take opiates. He was afraid of fentanyl. He didn't want to die, so he was snorting methamphetamine. So we talked about the cost-benefit analysis of that. That young man is now in treatment. He's in inpatient treatment. Our single county authority was able to work with us to get him in the treatment. This is some of the things that we do as the Probation and Parole Department, the treatment courts do. We're interacting with these folks as they are coming through the system, whether they're convicted. Not all people in treatment courts are convicted. A lot of our treatment courts are pretrial diversion. But the treatment courts are voluntary. People want to change. We have dedicated employees, staff, treatment providers, probation officers that are willing to help and deliver that change. One thing that I will be remiss to say is that we talked a lot about problem-solving courts, but county probation and parole supervises over 85% of the individuals on on street supervision in Pennsylvania. So the probation and parole departments are doing a lot of good work with the individuals that come on. And I would say over 3/4 of the individuals that we supervise statewide have a drug and alcohol substance use disorder for which they're working to have a better day tomorrow. So thank you for your time.
Thank you. Ms. Moralia, thank you for joining us today. I know it was a difficult day to come in. It's crazy out there and the roads are closed, but I appreciate you getting here. The floor is yours, 3 to 5 minutes in that range, not held real strictly, but thank you for being here.
I will try to wrap up the last 25 years of my life in probably about 5 minutes for you guys. My name's Jessica Moralia. I don't think I'm familiar with any of you individually. I'm a mother. I'm a sister, I'm a daughter, I'm an aunt, I'm a cat-loving chicken farmer, I'm an assistant district attorney, I'm a judicial law clerk, but most importantly, I'm a person who's in long-term recovery. I became clean through the Luzerne County Treatment Court, and I am celebrating 18 years sober this year. It was this past June that I celebrated 18 years. Thank you. So I started using when I was 13. I was in 8th grade. I came from a 2-parent household, middle class, working parents, single family home. So I have no idea why. I could never tell you why it started, but I could tell you how it kind of ended. I overdosed. I was in a coma for days. I had been arrested several times as a juvenile, even as an adult. Friends of mine died left and right. I never stopped using. All of that, it didn't matter. The only time I stopped using was in 2006 when I was accepted into the Luzerne County Treatment Court program. I had been arrested for 2 sets of drug trafficking charges by the Pennsylvania Office of Attorney General. They surrounded my house, and at that point, I was either going to go to jail or die. There was no doubt in my mind. In 2006, while my charges were pending, Luzerne County Treatment Court was created. I was arrested in 2005, and the program wasn't yet established. So thankfully, the criminal justice system doesn't work as fast as it's meant to, because if it did, I wouldn't have had this option. 2006, I was accepted into the program, and suddenly I was held accountable, and suddenly I was inundated with services. I met with a judge once a week, a probation officer, a case manager, a treatment plan that was completely designed for me and me alone. Everybody's treatment plan is different, but the criminal justice piece of it is the same. At that time, when I first went in, I was still in active use. I was not sober the day I got accepted into the program. I probably used that morning knowing it may be my last time. It worked. Having that team of people around me worked. The team encouraged me to go to college, so I did. In 2008, I graduated with my associates in criminal justice. In 2012, I graduated with a bachelor's in criminal justice. And in 2016, I graduated with my Juris Doctorate. All 3 of those being with honors distinction, and I graduated #1 in my class in law school. Initially, I was denied my law license. I passed the bar exam, and I got the letter that said, "Congratulations, you've passed. However, you are not of good moral character and fitness." I had not been rearrested. I had done everything I should have been doing, giving back to the community I once terrorized. I actually received pro bono recognition in law school graduation for working and interning in Luzerne County. In 2018, January 22nd, 2018, I did receive my law license after an appeal. In 2020, I became the criminal defense attorney for the exact treatment court I graduated from, for the Luzerne County Treatment Court program. Some of the members of that team were the same members from when I went through the program. In 2022, I became the supervising prosecutor for all the treatment court programs in Luzerne County. Today, I'm a judicial law clerk for Judge Sklarowski, who is the treatment court judge in Luzerne County, and I'm also an assistant district attorney in Wyoming County. I am a very proud member of the National Treatment Court Alumni Association, the Pennsylvania Association for Treatment Court Professionals. I'm a founding member of the Alumni Association for the Luzerne County Treatment Courts, and I'm a volunteer for Lawyers Concerned for Lawyers. Literally none of this would have been possible without treatment courts. I was arrested. I went through the typical criminal justice system. That didn't help me. Putting people in jail doesn't help them. Giving me services and supporting me was all I needed. And I think my little 5-minute blurb I could do in my last 25 years shows you that. Statistics, 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 numbers, numbers, numbers. I'm real. And if it wasn't for a treatment court, I would not be here today. I would probably be dead, maybe in jail, but I would probably be dead with the way the drugs trends had changed. So thank you guys for giving everybody the opportunity today to listening to us. Treatment courts are important, and I really want you guys to see that too. Thank you.
Thank you. All right, we're going to go to questions. Representative Chairman Doyle. Heffley, sorry.
Thank you, Chairman Kale. And thank you once again for coming down here. Dr. Lynch, I think I could probably sit and talk to you for about 2 hours to get some insight. And Judge O'Neill, thank you for all your work and leadership in getting drug treatment courts accepted in Carbon County. I know you came up and spoke to us, and now we do have an active drug court, and we're seeing those successes from that. I guess I have a couple of quick questions. First, for Dr. Lynch, as you see these drug trends coming in, how do we like move forward with MAT if we're seeing more of the cocaine? So I think in your testimony you said about the stimulants, and I guess it goes to what came first, the fentanyl or the stimulant. So I'm hearing a lot in the area where fentanyl is being put into, you know, meth, cocaine, and also in the marijuana that is being sold on the street. So is it the fentanyl or the opioid addiction that is driving people to the cocaine with the fentanyl, or is it the cocaine and then people are going to the cocaine with the fentanyl in it? And I guess I'm just looking, you know, out a couple of years, what trends are coming and where do we need to address it?
Absolutely. And yes, I'm trying to do that as well, look out a couple of years, and as you know, it's very difficult. Fentanyl, you know, I think I saw data that was present in about 41% of cocaine samples and 17% of methamphetamine samples. People I talk to and treat often use them separately. They use them for different reasons at different times. Usually that combined kind of sample isn't what they're intending. And as far as treatment, as you likely know, there are no sort of similar medications that are approved or work in the same way for stimulant use. But people who have both opioid and stimulant use disorders often both get better with really good, rigorous treatment, including medications of the opioid use disorder, but not always. For stimulants, actually, there's something called contingency management that's very effective in studies for managing stimulant use disorder, but it's challenging because it is essentially, in essence, it's rewarding for the kind of positive steps and behavior. So you set goals and rewards, even sometimes sort of monetary gift cards, those kinds of things. And in studies, they've actually worked very well. It's challenging in the sort of the actual real-life treatment landscape, but there are a lot of data to support it and a lot of work, certainly at the federal level, where regulations make it challenging. There's limits to how much you can sort of do that for folks, but that is something I think that's coming as stimulants become more prevalent. But for now, I think there's still so much gap, as you know, for treatment, good treatment of opioid use disorder, availability, and then making sure that people get it and stay in it. But we find that people who use both frequently do better. Medications for stimulants, there are some that can be effective and are sometimes used in combination with behavioral therapies and sort of just long-term engagement, drug testing for accountability, reinforcement, and those kinds of things. So it's a challenging landscape to try to treat stimulant use disorder, whereas with opioid use disorder, we have much more clear data of effectiveness, particularly with medications in combination with social and behavioral supports. If that answers your question.
Yeah, because we are seeing that, and I guess it's going to be an adjustment that's going to be made on the treatment end of it, because from my understanding of the opioid, it's a physical and it's a physical addiction as well as just wanting the high because of the physical illness that you feel by not having that opioid. So it was the question so we're going to have to continue to evolve in treatment as these new trends come in. And I think that's one of the things that we maybe have not always looked at. Because back a couple of years ago, we were focusing on the prescription drug, and we kind of cut that pipeline off in a sense, where we're not over-prescribing as much as what we were. And you really have seen that. But yet now we have fentanyl, and we're not seeing the decline in the overdose deaths that we thought we would if we had stopped that, which was a good thing to stop, don't get me wrong. So I think that's something to be looking forward. The second question was naloxone, and I read your testimony. So naloxone, and there's other prescriptions like naloxone. And one of the things I found is that from what I heard, was that the xylazine and other drugs like that would suppress the reaction of naloxone and make it harder for somebody to be saved, essentially, by naloxone. But in your testimony, you don't have that direct link. You're not seeing that.
Yeah, so naloxone does not reverse xylazine, but it still reverses the opioid, which is the thing that people die from in an overdose. It would be rare or uncommon to if somebody only used xylazine to sort of overdose and die in the way that we see with opioids. What is different is when we give naloxone to somebody who's used fentanyl that has xylazine in it, they will start breathing again from the naloxone, but they won't wake up because they're still sedated. If you mixed a benzodiazepine in with it, you would see the same thing, and we have. And so that can be confusing, I think, to the response, because what you're expecting when you give it is the typical response, which is to start breathing but also wake up. And that's how you can sort of know, okay, good, this worked. But if somebody starts breathing but is still very sedate or hard to wake up, that I think, especially for bystanders and first responders, can be very confusing and lead to sort of giving more naloxone because you're looking for something that likely won't happen, but you have saved their life by getting them to breathe again, particularly then get them to the emergency department. So that is typically what we see with naloxone administration with fentanyl plus xylazine, which is essentially where xylazine always is combined with fentanyl.
And xylazine in itself can become somebody can get addicted to that as well, from what
Yes, and especially physically dependent, whereas when you take it away, then you have a bad withdrawal that kind of overlaps. It looks very similar to opioid withdrawal, but if I take away all your opioid withdrawal, say with like methadone or buprenorphine, you'll still have those symptoms because much like naloxone doesn't reverse it, those medications don't treat it. So we're giving other kinds of medications that are more like xylazine to help kind of soften that withdrawal syndrome. But if you don't treat it, it can be challenging because as you're trying to get people into treatment through whatever mechanism, whatever door, window we can get them into, if they're feeling bad because we're not addressing that part of it, then they will disengage because they feel bad, because we're not addressing all of the issues. So that has been a challenge, I think, that we're still figuring out the best approaches for and developing data to make sure that we treat it.
Thank you. And Judge O'Neill and Pawlowski, Mr. Pawlowski, thank you for being here. So as the drug courts have proven to be effective and work for some folks, I guess one of the things, and I just had a sit-down discussion in my office last week with some law enforcement officers because we have there's always issues in every community just to try to better get a handle on it and see what we could do to help them address it, working with the court system. What do you say to the law enforcement when they have somebody who just is absolutely refusing to go into a drug treatment court or any type of treatment, but yet is continuing to use and continuing to have run-ins with law enforcement? How do you, I mean, other than just incarcerating that individual, what other tools can be used to try to get them into some type of treatment?
Well, there's the old phrase that, you don't begin to see the light until you feel the heat, and it's a fine line. See, we get most of our participants at a crisis time, at a window of opportunity time, whether, it's an arrest and an incarceration, or most what we see are these serial probation violations to where they're in and out, in and out. And because there's no treatment in a prison and there's no reentry programs really anywhere in the state where treatment should start. It should be starting at the time that we have them and we can begin to get their attention, as opposed to, hey, do you want treatment court? Or some judge will probably, give you probation. We have had probation reform in this Commonwealth, but it hasn't been attached so much to real treatment behind it. It's, let's not keep people incarcerated. Let's not keep them on long-term probation. But it doesn't really speak to a brain disease, meaning that's who the most is there. What we started in Montgomery County was what we called a top court, a targeted opioid phase court. And it was modeled after a Buffalo treatment court, a much bigger perspective in the city of Buffalo, and they were also a kind of a single authority type of court where they could do it. But the idea is meet them right where they are. In top court, what we do is we identify them quickly. And we did it back when the opioid overdose crisis, and at that stage they needed to have a opioid use disorder. However, we got them out of prison right away. Now that was risky, but the act of coming in, just the act of saying, hey, we're here for you. We're going to do what you want. We're going to get you out. However, we're going to get you right into treatment, and you're going to see a judge 5 days a week. It was a very intense program, but it was simply meant to keep them alive. We had that, we were driving, and that was very successful. It's a precursor. Then once they begin to see the benefits in their life of some even minor recovery, they begin to feel better about themselves. They have some hope, and the idea is then you can continue on. So early intervention, which Chris had talked about before, identification early. If you show them, and you're involved with them, as opposed to just having some lawyer go up who has their own ethical, to say, well, I got a deal here for probation, or you can do this 18-month-long drug court. In this day and age, they're going to choose probation because it's the brain disease talking. It's not their life. It's very hard for them. They need to get out, and they need to get using again, and that's the problem with the disease. So there are ways, but it's early intervention. And actually where we've seen the changes, law enforcement is our partner now in treatment courts. Adding law enforcement to a treatment court was really, really smart. It came out of the National Association, which is now called All Rise, but getting law enforcement in, you're just partnering up whose traditional role was to lock them up and to make the community safe. You can make a community safe with treatment courts. They are not, they've been called hug-a-thug courts, or, if they're out in prison, why you treat, because it works. And that is drawn law enforcement because they're very pragmatic. If we say we have a solution, it's much better to offer that than it is to simply, where we have none. There is no solution in prison other than MAT. We will keep them from getting sick in prison with MAT because it's now in our prisons. But other than that, there's no cohesive transition out of prison, and that's a problem.
Thank you. And just one follow-up question to throw it out for the panel, and I appreciate you all being here, and I know everybody has questions. The opioid settlement money, in a lot of ways, that money has come back, and pretty much everybody has their hand out for it. I was speaking with a group, and I said, we really need to look at this money as what it is. It's blood money. It's all your friends and that died of opioid overdoses or prescription drugs, or families and lives that were destroyed. It's the grandparents raising grandchildren. It's the children today that are being born with substance use disorders or addicted. How can we better utilize those dollars through some of the programs that you have? Now, there's been some back and forth whether some of those dollars can be used to treat xylazine, for example, or trank, as they call them on the street, and other things like that. How can we manage to use those dollars that are sitting there? If not, I would say give it to the grandparents raising these grandkids, because they're struggling. They come to my office all the time. How can we better utilize those dollars in our communities?
Treatment. I mean, it really is. I mean, if you don't have, we wouldn't do this with any other disease that became a crisis. It's treatment, and that's where the money, and if in the criminal justice system, drug courts can deliver that best, then funding for treatment courts is an important objective of the opioid money. But, hospital warm handoffs for, giving this, the emergency room physicians some power, and that's legislative. We do it in mental health. We can commit involuntarily in mental health, but when we identify a deadly, disease, and they're going to go back from that emergency room out there, if we don't have a program that we can have what they're called warm handoffs, we're really these are corpses under suspended sentences. They come in, they can get diagnosed, they can be given Narcan, but if there's no treatment, if there's no way to get them into comprehensive, cohesive treatment, then they just come back again. And I mean, I'm sure the doctor would testify to that, but it's treatment. It's where the money needs to be.
I agree with Judge O'Neill with the treatment. It's the number one priority that that we need. But also, we've been very fortunate in Chester County to partner with our single county authority, our drug and alcohol agency, and our district attorney's office to increase drug testing for those on treatment courts and probation and parole. So now, with the opioid funding, we're able to test every individual every time for opiates that comes through. And that's not something that we, budget-wise, were able to do in the past. So now everybody that's coming through is getting that test. And then, obviously being referred to treatment and going from there. But additionally, we're using things like certified recovery specialists that we're partnering with our treatment courts, that we're having work with the individuals that are on active supervision with our treatment courts. So having someone who's been there, done that, working with them and saying, I've been there, I know what you're going through, partnering with them when they go to court, we're able to use the money for that. So I think the treatment, testing, certified recovery specialist all come under that umbrella of treatment, but that is the solution to this. That is the solution to this problem, is having as much treatment available to us as we can possibly afford.
I agree with that also. I do not, in any of my positions, know much about funding and how any of that works and getting grants. I'm sure Chris does, of course, but it is treatment. I don't ever want to hear a person say they can't get into treatment and they have to go to jail instead. That should never, ever be an answer. You may have to go to jail till we can get you a bed, but that should be immediately. You should be able to get in treatment immediately, not 2 weeks from now, not, maybe some other time. No, you can't even get inpatient because the funding's not there. That should never be a problem. We have a great single county authority in Luzerne as well, so if you don't have insurance, none of that becomes an issue. They get involved. But it is money for treatment. Treatment, treatment, treatment. That is what we need. And not just substance abuse. I think it's mental health, too. A lot of these times you're going to discover these people are self-medicating. There is an underlying mental health issue, usually with the substance use disorder. So both those programs, both mental health and treatment, and they should be one and the same. They should be together. And then I think we're going to see a bigger difference. Jail's just not the answer. Or probation, because like the judge said, if you give someone, you can go for probation, be checking in once a month, or treatment court for 2 years, most people are going to run for probation. I always say you got to peel them like an onion. You're going to bring them in, and they're probably not going to want to get sober, and they're not going to listen, and they're going to hate you. You peel them like an onion, and eventually they're going to realize that we're just here to help. Everybody just wants to help this person. Nobody here wants to see anybody overdose or die. Nobody.
Just quickly, struck a thought with me. When we talked about the review sessions, I believe I touched on that, is that everyone comes in front of the judge for a review session. You have people in all phases of the programs that come before the review session. So you have someone new that's coming in from the street that's still, what you talked about, they don't want to do it. They still want to be in that game. They still want to get the drugs. They still want to be high. But you have someone who's in the fourth phase who's like, hey, they can stand up at a review session and say, again, like the recovery specialist, but I know what you're going through. This is how I got through it. This is what is better in my life. This is how I feel better. You can do it too. But it's that working with one another, being part of that team, even the individual participants that are there that help one another through that process.
All right. I also wanted to mention that Representative Flick has joined us online. We have a couple more members that want to ask questions as well. Representative Rigby.
Thank you, and thank you all for your testimonies this morning. Doctor, we look at the overdose deaths. Where does Pennsylvania stand against the national average?
Yeah, I would have to look at with the most recent updates, because there's a lot of ups and downs, and Pennsylvania is generally on a downward trajectory. In general, top or bottom, 5 to 10, typically. Worst overdose rate by population. Often West Virginia is first or last.
And are we seeing drugs now that Narcan won't work on?
No opioids that Narcan won't work on. Narcan still works in the typical dosing regimen that we've used on opioids that are on the street now.
And Judge, you talked about the substance abuse. People you're dealing with, 70 to 85% returns, has been reduced to 30% because of the 18-month courts. And I'm just curious, as a former chief of police, I was called in to identify a body, a young man that I had arrested prior, who had been through treatment 4 times. And it's a 90-day treatment. Are we doing something wrong when it comes to our treatment centers? We're doing 18 months through the courts, and you're at 30%. We're putting them into a rehab center, a recovery center for 90 days, and at least this young man 4 times had lapsed back until it finally cost him his life. And I'm just wondering, is 90 days enough, or do we need to look at that differently too now? And if it is a disorder, is it something that we can get them into treatments and possibly find a way to have it covered?
Well, clearly, look, I have a saying, and I don't mean treatment centers are good for what they do and how they provide. They are serious about getting someone started in recovery. But we have a saying, the reason treatment courts are so long is, you know, that 30, 60, 90-day, these are models, whether they are insurance, whatever the funding models are for them. But if that is the only intervention you're going to use, I like to say you might as well just give the substance use disordered person, send them to Disney World. The outcome will be the exact same if it's only an inpatient model you're using. They'll have more fun, but the outcome will be the same. I think what we know about recovery is a holistic, it's an all-centered approach. You know, we call them treatment courts. I mean, there's a medical specialist here that knows that we do the same with other relapsing disorders of your life, with heart disease, diabetes, you know, change your life, change your lifestyle. You know, we don't deprive diabetes, you know, sufferers, you know, insulin. Well, that's the same thing with medication-assisted treatment. What it is really meant is to assist in the treatment. It's not a solution. You know, these are not all long-term solutions. And what we know is that in our court, that is an evidence-based practice. And we're fortunate in Montgomery County, and I cannot speak to the rural counties, but inpatient is a vital importance because it's like going into the, you know, intensive care. You're coming out of a prison. We know you will pick up again. If we can get you transitioned from the prison, and that's where this turnaround is important. Identify, get them out into inpatient treatment, and everything else then is part of a recovery plan. As Jen talked about, a treatment plan about her particular substance use disorder, how best to treat it. But, you know, many of them step down into halfway houses, recovery houses. The growth of certified recovery houses in this Commonwealth should be a priority. A sober living environment. When they're in a treatment court, that sober living environment works. You step them down to intensive outpatient treatment. They step down into outpatient treatment. That's what it's a medical model. That's what they do. You know, you rehab along the way. It takes time for bones to mend and heart disease to be brought under control. Why aren't we doing the same thing with substance use disorders? It boggles my mind, but that's why it works. Can it work alone? Yes, if the person has supports, family support, community support, you know, employment support, if things are there to replace when they get out of inpatient treatment. But standing alone, it's not great. It has to be part of a long-term recovery plan. I don't know what anybody else.
Some of the addictions we know come from, you know, injury where they've been put on certain meds. We know certain meds they shouldn't take now, and most hospitals aren't using them now, but they did years back because we didn't know better, and the addiction begins. But I was curious as to, do you see a trend? Is it an environmental location, city versus suburb? Jessica spoke about, you know, where you grew up in your household, and all those things kind of shot down my thoughts of what's causing it. So again, as it goes back to being a mental disorder, or do we see trends of certain areas more than others based on environment and their surroundings? Or it really has no bearing on any of that?
It's an equal opportunity killer, you know, opioids. You know, when we've all learned it, you know, it's not something, it was easy back, you know, 30 years ago to think that was just an urban problem, but it is not.
I'll say, I mean, there are trends you can see, particularly through sort of growing up and adverse events, and you can imagine that with the explosion of substance use and overdose deaths, the impact that's had on children growing up, and that is a risk factor, but it's not always there. We think of it as sort of a three-legged stool. There's genetics, there's lifetime sort of experience, trauma, ability to cope, other behavioral health, and then there's the chemical aspect of it, and that all can contribute in different ways for different people. But as I think I put in here, the county with the highest rate of overdose deaths was Montour County. The second highest was Philadelphia County. So, I mean, those are very different places, and people live very different lives in those places. And I think that just gets to the point that wherever you are, whatever your background is, it could be what looks like the best possible environment, and you can develop it, or the worst possible environment and not. And it's really hard to predict, but we know it affects everyone.
I was going to say Johnstown was at one point the second highest opioid visited overdose. And again, a very Cambria, yes, unfortunately we are. Thank you all. Thank you, Chairman.
Representative Slagle.
Thank you, Mr. Chair. I kind of wanted to drill down just a little bit more on the treatment court, problem-solving court, in terms of creating such a process. And I was wondering, does doing so necessitate increasing the number of judges that preside in those courts?
Well, you find that treatment court judges have to want to do it. I gave you my story about how, I like to consider myself pragmatic and evidence-based practice. That's why I wanted to do business. I was a criminal division judge in a very large county. My personal story about how I got it funded, I was the former county solicitor, and the 2 county commissioners that were in there, I was so passionate about giving this a try that I got funded by our county commissioners and have had consistent, nonpartisan funding for the last 18 years. That is not, what happens. It's not so much the number of judges, but it's the funding for the probation departments. You can't have a treatment court without a probation department. You can't have, that is set up to have what we call substance use disorder supervision. So the number of judges, it's, maybe, that now that we see what impact we make. There are judges in the county, but it's about the funding for the treatment court itself, the treatment and the supervision. So we're fortunate. In Montgomery County, we have a veterans treatment court and a judge. We have this targeted opioid phase and a judge that wants to do it. We have a mental health, behavioral health court with a judge, and we have large numbers because they care. They all signed up for it. Some counties, it's just too tough. Rural counties, we have regional treatment courts. I think the AOPC had this initiative. Their problem-solving culture division. We have a regional treatment court for some of the more rural areas. That's working. So I don't know if it's more judges, but it's certainly more funding.
And I think that Judge O'Neill can probably drill down on the time, but I was meeting with my judge who runs our treatment courts, and she was saying that they just did a study. The average judge spends about 17 minutes with each defendant through the course of their case as they come through for a regular case. But when you talk about treatment courts, it's well over 350 minutes. And when you talk about a judge and how many cases come before a judge a day, 17 minutes is a lot, and 350 plus is also a lot. So you see how invested the judges are in the treatment courts. In Chester County, we have 4 treatment courts. We're starting our 5th. And we have 1 judge up until now. She was running all 4, and we are looking to expand. So it does take a lot of judicial time. And as Judge O'Neill said, the probation department, they are, whether it's the pretrial side, the conviction side of the treatment courts, the probation department is the driving force along with the rest of the team, but they're the ones providing the intensive supervision. And as Judge O'Neill said, the funding for county probation has not changed since 2003. It's been the same at $16 million split across 65 counties. Our treatment courts have expanded. Our people that we supervise have expanded. The staff has expanded. And the county takes that on. But if we were funded at a greater rate, we could provide that much more and better services.
Thank you very much for your insight. I appreciate that. Thank you, Mr. Chair.
You, Representative Gregory.
Thank you, Mr. Chairman. Great conversation today. I have questions for each one of you, but I'll be as quick as I can. But I do want to recognize Jessica. Thank you for whatever you had to do to be here today. As a 14-year friend of Bill W., I am grateful for you getting the gift of desperation when you were faced with that difficult circumstance. But I think you might also be able to talk a little bit here about educating folks on how it is a disease for the addict, but can you also share what your experience is when it comes to the disease of the family? Because when a person is away for treatment, it also gives the family that time to heal because they need to heal as well so that when the addict comes back into the family, that they are not coming back into an addictive situation. So thank you for that first question.
Yes, so Unfortunately, in my experience, I did have a family to go home to, but you don't see that a lot. I probably was able to succeed so well because I had that. You know, my family, my parents weren't addicts. They were actually probably completely disgusted by me at one point. But even if it's not family, if it's whoever your support system is, right? Whoever you're gonna go home to, they also need to be a part of the treatment plan. They also need to be brought in. If you're getting out of an inpatient facility, they should be brought in for that reentry, for that recovery plan, whatever those next steps are, because they have been affected. And maybe, you know, I always say this, nobody wants to steal their grandmother's ring, right, and pawn it off. Nobody wants to do that, but you've done it, and you've burned a lot of bridges. So even if it's part of the aftercare in an outpatient therapeutic setting, you do have to bring whatever that support system is to get involved. They will not make it if that support system isn't also being trained on how to help that person in recovery, because most people don't know what to do. Most people will give their kid the $20 and they know they're gonna go buy a bag of heroin with it, but in the moment, it makes their child stop freaking out and screaming at them and terrorizing their household. So a lot of loved ones don't make the right decisions when they think they're supporting that individual. So it is getting them in part of the recovery plan, the reentry plan, whoever that support system is gonna be. And one of the best things in treatment court is watching people build those bridges again, and having their loved ones show up to court and, you know, watching that you fix that relationship, because it is a team effort, 100%. I mean, I sit here today and I want to get high every day. It's been 18 years, but you don't get over it. You know, now I buy too much coffee and too many pairs of shoes. I'm an addict. That's just what it is. I'm addicted to more healthy things, maybe not coffee. My cardiologist would not agree with that. But the shoes, nobody could really disagree with. You know, it's just changing the way you view things also. You know, again, I overdosed. I was in a coma for days. My parents, the doctor had to discuss, if I woke up, would I have brain damage? Like, no idea what the aftermath was even gonna be. And guess what? As soon as I got released from that hospital, I went to go get high. It didn't matter to me. It mattered to my parents, I'm sure. So making sure they're able to be involved. And I don't know, again, if that's a funding thing or just an appropriate aftercare plan, but they have to be involved in whatever the next step is gonna be.
Thank you. Dr. Lynch, over the last several years, have medical schools improved the amount of attention and curriculum for students to make sure that they leave medical school prepared also to deal with the addiction and recovery and treatment, because they are prescribing? Overprescribing certainly brought us to where we are, but medical schools only maybe until recently, if you can update us on where they are in educating medical school students to prepare them better for what they're going to face in the rooms when it comes to treating the whole patient. Thank you.
Sure, absolutely. The short answer is yes. Medical schools, certainly across the Commonwealth, but across the country, have placed greater emphasis not only on pain management and prescribing. I mean, opioid prescribing has been and will continue to be part of medicine. The question is, how do you do it? How do you do it responsibly? And how do you monitor its impact appropriately? In addition, there is greater emphasis placed on the treatment or discovery, identification, screening, and treatment of substance use disorders early as they're developing, and even on sort of the adolescent sort of predisposing risk factors, and you know, trying to treat those. Now, it may not be early substance use, it may be early behavioral health or other things, but absolutely. In fact, with updates to DEA licensing and prescribing, part of that is an understanding that that curriculum, which used to have to be sort of extra and voluntary, is now just a part of the medical school training curriculum.
To our law enforcement, thank you very much for your early recognition of this issue back in 2002, and thanks for your work with your SCA. We have a very good relationship with our SCA in Blair County as well. But thank you to UPMC Altoona. that they are providing a crisis stabilization unit that will open in 2025. It can't open fast enough for my liking, but I appreciate Governor Shapiro acknowledging the need for it in Blair County to the tune of about $1 million. Could you talk about how crisis stabilization units, taking folks in active addiction in crisis, not putting them in the ER, and how these crisis stabilization units can really help get the process started towards long-term recovery? Thank you.
Well, obviously, I think you're at the forefront of it, because I would love to have one of them in Montgomery County. I would love to have them. You know, you've heard my remarks before that it needs to start where the crisis is. You know, we read, you know, the difficult even sending, you know, what kind of centers will put in Kensington, which is at the forefront. It's an issue that, you know, that Philadelphia has had to deal with for years, but this idea, when you say crisis center, you know, obviously any type of early intervention, it doesn't have to always be criminal justice intervention. True, you know, law enforcement, criminal justice reform is approaching this with a real evidence-based mindset, the things that work. You can keep a community very, very safe if you start to treat the people. You've got to remember, what are the crimes that are symptomatic of a substance use disorder? The biggest one we have now, and we're working, is driving under the influence. Driving under the influence is just not, you know, the local guy who goes to the bar and drives home. It is, all of them are, you know, multi-polysubstance abusers who are driving your vehicle. Well, you know, through the work with PCCD, you know, the idea of being able to get those people into treatment as opposed to just incarcerating them away has made a significant impact. Again, any kind of program that would get an immediate intervention has to be successful, because this disease will, you know, continue its pathway to either the criminal justice system or death if it's opioid related, and anything. So obviously, I'd welcome and would love to study your model. The one other thing when we talk about intervention is this concept of recovery centers in our correctional facilities. That's where we really can make, because now they're in, the community's safe, and they're in, and if you can start them, what's happening is we're emptying our jails through probation and justice reform. We have in Montgomery County an entire wing of probably 300 beds completely unused. If we can turn that into a treatment center, which is my next objective, I think we can make a real impact, and the community can feel safe, because they have a much better understanding of what are the driving forces of crime that is related to substance use disorder. They understand the people who break into your cars, the people who break into your house. The retail theft complete epidemic is all driven not by people who need products because, you know, they can't, but they are the number one. They can get them out on the secondary market and sell. That's why diapers are the most, you know, the one product that is stolen the most. That's why you start seeing a lot of stores closing, because they can't deal with the retail. Those are symptomatic of substance use disorders. If they are in prison and we can treat them, it's a start. It is a start. So anything that has the word crisis management in front of it is an absolute evidence-based practice.
And, Mr. Chairman, thank you for the extra minute here just to share a statement. You mentioned certified recovery specialists. I actually began the training to do that last Friday. I'm going to have some time on my hands, so I figured I might as well be a CRS. I can tell you that Pennsylvania is recognized as the most difficult state in the country to achieve that certification. 67 hours of training and then a test that costs $75. And you also have to have 18 months of recovery. I would only submit that if we want to look at what barriers exist to recovery and long-term recovery in Pennsylvania, that's one place that we can look, because CRS training is taking place and the people that are doing the training are not getting tested for a couple of reasons. One, the test is not easy, the training is long, and the test costs $75. In addition, for me to get online to apply with PCB, the Pennsylvania Certification Board, was impossible. It did not work. And I can tell you, addicts will get frustrated quickly, and if we don't find an easy path to getting in, we'll stop. And once you lose those people, you may not get them back. And so recovery has lots of different difficulties. And I'm sharing one with you because I lived it just recently, trying to get not the certification, but to get registered for CRS training. So thank you very much. Thank you, Mr. Chairman.
And I'll just add, in Luzerne County, I know we are sending people, you know, our treatment court, if you come back and you want to go, you've graduated, we're helping fund that.
Thank you.
And helping them sign up, like the case manager helps with all of that. So I know they are working on that in Luzerne County. But I know a lot of people don't take the test. I've heard that. They go through the course and they don't take the test. So I'm not sure exactly why. If we're offering to pay for it, they might just not feel confident enough. It could be as simple as that.
That is part of it. $75 is another. And the need for CRS is we don't have enough of them. And the pay for those is about $18 to $20 an hour.
So I'll say, when I went through treatment court, there was not anybody in recovery on the treatment court team when I went. This is a newer, you know, model here to have people in recovery on the team, and it was the hugest problem I had because I had a bunch of people who I felt were in their ivory towers, eating off their silver spoon, telling me how I need to get clean.
18 months of sobriety is a lot. It shouldn't be about the quantity of sobriety. It could be about the quality of the sobriety as well. Thank you.
1 day of sobriety is a lot.
Representative Flood.
Thank you, Chairman. This is Representative Flick from Lycoming and Union Counties. Thank you all for your testimony, and a special thanks to Representative Gregory for his expertise and for being a leader on this. I know we're running late, so I'll be brief, but whether it's Chester or Luzerne or Montgomery or Blair, it sounds like each and every one of you have a really good relationship with your SCAs. It's fantastic. Likewise here in Lycoming County. One thing we recently did, I just want to get everybody's opinion. Of course, the opiate settlement money goes to the counties. So these 60-some counties decide where to spend that. When I met with the 3 county commissioners in Lycoming County, each of them had different opinions, all good opinions, but difficult to decide where to go. I convinced them to do an MOU with the SCA and move all of the money back to the SCA because I feel like the SCA are the expertise as opposed to the county commissioners, which may have no background whatsoever. So I just am curious what maybe what Blair County is doing, Representative Gregory, or the other 3 of you, your thoughts on that model of pushing the money to the SCA instead of to the county commissioners. And again, thank you for being here.
Had you first. I just know in Montgomery County that the process has been long. I mean, we're seeking that meeting with the county commissioners. I mean, the idea, once, if the county commissioners shift it to us SCA, then it's a statement that we're taking the opioid money and looking to the future of those that have survived but still are suffering their disease and treatment. So I'm definitely in favor of that, but I recognize they have many other related programs, which are CRS, you know, MAT, getting, you know, these abilities, setting up recovery centers in our correctional facilities. I have a host of, I'm just waiting for the opportunity to meet. I don't know. Chester.
And I can't speak to the specifics of how it works, but I know that our single county authority, our drug and alcohol department, has a large control, or a big control over the funds. Our district attorney also has a set of funds that has gone to his office that he is working to turn over to the county and the single county authority. So all the funding that we have requested and received through the probation and parole department, we have made to our single county authority.
I live in Westmoreland County, but I work in Allegheny County, so we've been working quite a bit. Allegheny County is a different kind of setup. They have a Department of Human Services, and within that is the SCA, and there's a lot of contracting. But they're controlling the money, and really the focus has been that continuum of care, sort of creating a web, essentially, where multiple points of entry, lots of outreach, warm handoffs from the emergency department, rapid telehealth access, and transitions of care, including a mobile, like an app, a platform to help with rapid scheduling, transitions, supports, access to naloxone, and even pharmacy benefits, things like that. So it's really trying to be a comprehensive and holistic approach, thinking of it as any entry point and making sure that once they're touching any part of it, the connections are really simple and facilitated. It's challenging, And the other part of it, I think, with any of these opioid settlement dollars, while they're 18 years, which is a lot, we all know that it's not, and that when that comes due, we'll also want to have evidence and data to support a continuity plan and a sustainability plan, whether it's through governments, through private health insurance, public payer, whatever. However that's going to look, we want to see the data that it's been effective so that we know how best to reinvest or allocate dollars moving forward beyond that, as opposed to just giving it to something that we know is going to fall off the cliff when the dollars end.
All right, again, thank you so much. It's, I think what we've seen here, Chairman Kale, is the ability to work together. And each and every one of the testifiers today certainly work with, with their counties and with their SCAs and with other agencies. And just one more point, we've sort of here in Lycoming County also got MH to work with DA, to work with the county prison, to do MOUs, to look at recidivism rates, and that is working out well too. I don't want to go off the rails there, but thank you, Chairman, very much.
Thank you. Representative Flood.
I'm just going to jump ahead of her again.
Thank you, everybody, for your testimony. It's very important and insightful for us to hear this here in the legislature. I was just wondering if you can kind of walk me through the process of how an individual with addiction is referred to your treatment court. Is it based on your crime, on the level of crime? How does one qualify to get into the courts, or maybe have to go straight into the criminal system?
Yeah, that's a great question. First of all, I want to commend Northampton County's treatment courts. I remember they came and we were kind of a mentor court to them. And now that I see how they have grown and the community resources, which are so valuable in the partnerships with, I believe it's the hospital up there, is just incredible what they do. So my hat's off to Northampton County is really at the forefront of growing. Different counties are the same, but much of what you're going to see is still going to go back to the district attorney's office. They are most counties are a gatekeeper, meaning if it is a new crime that comes in, they have to certainly keep an eye to the community interest in regards to violent crimes and crimes that have victims that are identifiable and maybe opposed to it. They have to be very aware of that. So they will have the ability to say that doesn't qualify. Most evidence-based practice treatment courts have that set up. You have to have the DAs as part of your team. But many are driven by also the fact that many of them are these post-sentence courts, which are when they're on probation and parole and they have failed. That's the main driving force of treatment courts, meaning regular tracks of probation will fail these individuals because they have this disease that is just so resistant to any kind of intervention. So treatment courts, where they perform the best, is the high-risk, high-need individual. When you say high-risk, high-need, and risk isn't just risk in the community, it's risk of being able to perform better than on a regular track. When the DA's here, high risk, it's difficult. When we're talking about, criminogenic needs and the like, they're hearing risk in the community. That's a tough one to get over. But working with the district attorney's office and getting a comprehensive list, and then agreeing that, these aggravated assaults, these sexual assault crimes, these different ones, the community doesn't want it, and I don't think it's good for treatment courts. And you're not finding a lot of the true substance use disordered individuals in those categories. You're finding them in the thefts, the driving under the influence, the possessions. Those are where you're finding them. So the DAs are much better. Once they refer them in, then it's a process that I think I can speak for all the treatment courts here, is that the treatment court itself is ready to roll. I mean, the coordinator is up and on that case the minute it's identified. The public defender is usually the liaison. They're up on the case and ready to go. And the goals is to reduce the time from arrest to admission into your program. And so those are an evidence-based practice. We talked about the 10 key components. All Rise has these evidence-based practices for all of the team members, the judge, the prosecutor, the defense attorney, the treatment community, so that That's the main goal, is to work towards. So we've identified it, but the district attorney is a very important gatekeeper in that process. I don't know what the other counties.
So we just went through this in Chester County, and I can give this to you when I leave. We made a flow chart of how it starts from your arrest, and if you waive your preliminary hearing, what happens, and if the DA rejects your case for treatment court, what happens. So I can provide that to you today. But the one thing that I'll add, as Judge O'Neill said, probation violations sometimes are the drivers of treatment courts. In Chester County, we were not a county that typically put violations of probation and parole in the treatment courts up until now. Our new district attorney has come to us with an idea that he wants to do that, and we're looking that it is going to tremendously expand our treatment courts, and it's what we need. It is the high risk, the high needs people, working with the most seasoned probation officers with the most amount of resources. And I'll say, when we talk about risk need, one thing to remember, as Judge said, risk is not always risk to committing new crimes. It's risk to using, to relapse, risk, for many different factors. So we use validated risk assessment tools to determine someone's risk and need, and then that's how they're placed in certain tracks or pathways of the treatment courts.
I would like just to add that of course, the DA's office is important because they have to approve these people for it to get to the next step, but that starts with law enforcement. Sometimes the district attorney doesn't even know about that case until it's past a prelim. You're months in at this point. Training for law enforcement is also very important here, allowing them to be able to identify these people on the street and then having that relationship with their DA. And when I was in Luzerne County, they would call me, my personal cell. It could be the middle of the night. They knew that. Call me if you have someone that you don't think you should be taking to the jail, that there's something else going on and that there's a better route for them. So I think it starts more with law enforcement and training for law enforcement, how to identify people with substance use disorder and mental health disorder, and also training them to want to help those people. Typical law enforcement, they are trained to arrest, to take to jail, to get their, they get a shot, they get credit for that hit. They don't really necessarily like all this hug a thug, diversionary courts. So a lot of training for law enforcement is a need as well.
Thank you. And I know that we talked about the importance of getting into treatment quickly. And so I know that it was discussed in Montgomery County that you have this availability. But I know in the past we've had discussions in Human Services, although I'm not on the committee this term, but at other hearings, that it's difficult to find treatment and placement for these people. So have you found it to be difficult to find placement for individuals so they can get treatment in a timely manner, given your treatment or your discussions with your treatment court?
Well, let them speak for their individual. We're very, very fortunate in Montgomery County. It's one of the wealthiest counties, and it's a large county, and there is a lot of treatment. We partner with inpatient treatment facilities, and we're fortunate. Our jail, that's the other thing that's such an important component. They are a partner with our treatment court, and they and their ability and their social services to identify applicants, and then once we do, getting them placed, we're very fortunate, and we can find funding for them. We have Eagleville Hospital, which is one of the premier in the Commonwealth, and they are literally down the street from the prison. So I don't want to speak to others, but I also am on the faculty of the National Association, All Rise. What happens is you go into rural communities, that's where the evidence-based practice has to necessarily fall off because there's just no regional treatment set up. And that's the hard part.
And when you have those situations, though, how do you choose? You know what I mean? If you have a limited number of beds, how do you choose through your treatment court who actually gets referred to those?
We get everyone in. That's amazing about us, and we're very demanding.
But in those areas,
in the rural areas,
in the rural areas where you don't have that opportunity. So
you can't make treatment providers open an inpatient treatment facility. I don't know whether there are certain models that maybe make money, but mostly it's not a model that's going to make a lot of money for a treatment provider to put an inpatient facility in a rural area. That's a problem. Regional treatment centers can help. But I would rather, some more rural, speak to it, how it works there. We're fortunate.
So Luzerne and Wyoming is actually a shared single county authority for their drug and alcohol, but completely different. Wyoming County, we don't even have a medical hospital, let alone treatment facilities. So we literally have to drive someone 45 minutes to Luzerne County to Wilkes-Barre if we need medical attention. So that's a huge problem in Wyoming County. Now, the single county authority, again, is the same, so the funding is there, but I think it's just the people don't know about it necessarily. That is one of the reasons I went to Wyoming County, actually. I plan to really try and make a difference there to bring programs. We have reentry in Luzerne County. We have every program you can imagine in Luzerne County, but there's nothing in Wyoming County. You basically go to state prison because that's where there's a great drug treatment program. We know that. The state drug treatment program is excellent, but you have to go to state prison to go there. That's not the answer.
I would just, not so much from the drug treatment courts, because that's not my deal.
Sure.
But from getting people into treatment, I just also want to point out, outside of the criminal justice system, many patients don't go to inpatient treatment, or don't even necessarily, some need to go, some don't necessarily need to go, even figuring that out as part of the process. But I think striking while the iron is hot is so critical. And I think, in areas where there are delays, because there are inherent delays, days to weeks even to get into outpatient treatment. So, the number of beds in Pennsylvania, and you'll hear these stats, is not necessarily low compared to other places. Accessibility is a different question, especially by geography. But even just getting to any treatment provider, and in a non-sort of compulsory way, many patients, even who would benefit from inpatient, don't want inpatient, and better to have treatment that may be not even to the level that they need than no treatment. And so we focus on that a lot. And one of the things that we've implemented just in the last few years to try to address that is actually telehealth, to be rapidly available, like within a same day or within a day, to at least get people engaged on medications while they work with their SEAs and local treatment providers to get into that, whatever that local long-term treatment can be. So I think there are different innovations too that can help address that. Mobile clinics have been implemented or are being implemented in some, especially rural counties. So there are other ways that we have to address it. I think in the interim, while sort of a bed available within a day everywhere, can be a goal. In the short term, I think there are steps to get there as well. If that makes sense.
So we refer, we're great as far as getting people to inpatient beds. We'll send people throughout the state to different counties, wherever our single county authority can get a bed. One of the things that we've heard a lot about today is, getting people to want to do treatment. And as the doctor said, sometimes people don't get inpatient treatment. That's one of the key things about LETI, the Law Enforcement Treatment Initiative. And you have that, and you have the treatment courts. There's a little bit of power behind each of those programs that say, you're going to do this, it's going to be good for you. And most of those people come out and they say, it was good for me, I'm glad I had that quick intervention. And it goes back to what I mentioned earlier about having folks from the treatment courts and even, with the district attorneys with LETI embedded into the pretrial services. So as soon as they're arrested, you have pretrial services that are part of the courts in most counties that can refer to the treatment courts, can refer to inpatient, get drug and alcohol evaluations, quick hits in the prison, out of the prison, into a bed, and into inpatient. And that's where the biggest bang for the buck comes. People are getting treatment and they're not in the prison.
So you talked also about community partnerships that you have. Do you help the individuals, once they get through the programs, actually get out through your community partnerships to help them find jobs if needed?
So we have a couple different things to talk about. One is that when we go through our single county authority and they're placing them in the inpatient, we have case managers at our SCA that are working with the folks while they're in treatment. And then as they get out, we have reentry officers that are working with individuals. And then through our reentry coalition that we just started recently in Chester County, we have employers that are coming to the table through our Chester County Intermediate Unit. They have a great program for employers to come, and they partner with the probation department. So granted, as the probation department, we can't tell an employer everything that's going on, But when you tell an employer that if you hire somebody and you give someone this chance, you can rely on the probation officer, and you can call and say, hey, Chris isn't showing up today. I know you can't tell me anything, but I wanted to let you know. The probation officer can jump on that right away, figure out where Chris is, why didn't he go to work, what's going on, and it's helping employers get people that come to work every day or regularly, and it's almost like that big brother looking over the shoulder for the employer that they're not even paying for, but they're getting as a return from the probation parole department and even pretrial world. That's why this court supervision, intense supervision, is beneficial not only for the taxpayer dollars, but it's beneficial for our employers and our workforce development.
Remember, employment is part of the phases of the court. It's not when they're completed the court. Usually you want the, it's much like the emergency. You want to get them stable in their first phase, which can last up to 3 months. Most treatment courts last 5 phases. By the second phase, once they're stable, they actually are a resource to employers, and they welcome them. I echo that, meaning we encourage our people to be honest and say you've got a lot of requirements of showing up for testing. You have to go to treatment, but if you are an employer, now these people have skills. They have great skills, and they had great jobs before and their disease robbed them of that. So employment is part of the program, and they're usually fully, if you can't graduate our program unless you're fully employed, we don't hold them up forever, but we push them into different community service if we don't have employment. But that is part of the program.
Okay. Well, thank you. Thank you.
Representative Nelson.
Thank you, Mr. Chair. I know we're pushing this really great information today. I wanted to, Dr. Lynch, it's good to know you're from Westmoreland County as well, so we can have some maybe follow-up or offline conversations. But it struck me in your testimony right at towards the beginning, you mentioned the significant difference between black overdose deaths and white overdose deaths. And I looked up your footnote here within the ODSMP. Can you touch on that a little bit? Because I wasn't really aware of that. It seems like it's based off of every 10 out of 10,000 people, but why is there almost double the difference in overdose deaths, or from your opinion?
Yeah, that's a great question, and it will be opinion because it's multifactorial most likely. And I think what's interesting or notable is that in 2017 the rates, and it's population based, which is what you're saying, because the absolute numbers wouldn't look like that, but when you go based on the population, in 2017 it was the same, the death rate, and before that it was about the same, and now it's more than double in black Pennsylvanians compared to white. Both went a little bit down in 2023, which is good, but less so. And I think it's a complicated question, right? I mean, that's one factor of humans amongst many, right? Socioeconomic and otherwise. I suspect it has a lot to do with access both to things like naloxone as well as treatment recovery resources. I think there's probably some long-standing historical sort of mistrust that may contribute to that. You could even talk about things like ambulance response times in certain zip codes versus other zip codes are variable. So I think it's multifactorial. The Department of Health actually recently published a paper indicating that in overdose victims who are black, they're far less likely to have received naloxone than white. Now, why is that? I don't know. We can only speculate. But I think it's a notable enough thing, not only its existence, but the divergence and the difference since 2017 is what strikes me in particular, because I think in that time we've all done a lot of work and a lot of investment to make resources available, but it makes me wonder if in those communities, again, whether it's based on race or socioeconomics, probably both, that potentially the access is just different. I don't have those same data for rural versus urban and things like that, but we know that amongst counties that are rural and urban, they're very similar in rates adjusted for population. But it's challenging, and I don't think there's a simple answer.
Yeah, so the naloxone, like we just had a recovery picnic, in Westmoreland County this past week for one of our organizations, and it's out, available, it's on the counters, it's in stores, it's all over, and you're thinking that it may not be to that same level,
Either
or?
available or taken, or, you know, I don't know. I mean, yes, I agree. It's been made very, very available throughout the Commonwealth, as far as I can tell. And it's.
Yeah, because that's a pretty, I mean, 3 out of 10,000 people versus 7.5 out of 10,000 people. That's a really big disparity. Next portion, unless comments along those lines or your opinions for.
I can't talk about race and why it's different for race, but I will say there seems to be a stigmatism with naloxone. We offer it when people are leaving our jail. If they want it, they can take it. We have it in the probation office. It's there. People don't take it. They don't take it when they're leaving the jail. They don't want it when they come in the probation office. I ask why, and nobody wants to talk about it. So I don't know what that is, but it is available. It's there, and it's a mystery to me.
And my second question is the RCOs. You had mentioned maybe in the prison, like recovery care organizations. We have a very successful RCO in our region. I think that aftercare component is, you know, including transportation, but it's not really, at least my understanding, officially funded through DDAP. You know, there are walk-in center funding. If it wasn't for our commissioner funding, I don't know that the RCOs would be able to sustain themselves. From your perspective, is that just an evolving area that DDAP hasn't, you know, started to say, hey, there are grants for RCOs? Or, you know?
I can address that. I was actually medical director for DDAP for a couple of years, and during that time, we did have a project moving forward, and currently there are, I think, 9 regional hubs that fund sort of RCOs to be like a hub for spokes. Like Unity Recovery is the one in Allegheny County. Not all of them, and I think Dream Life is probably what you're referencing, are funded in that way. But yes, outside of those 9 regional hubs that are meant to support recovery services to either treatment providers or others, they are not directly funded. And I think part of it is trying to develop a project I'm currently involved with, trying to develop the return on investment, sort of how can we quantify and figure out, and because you can think of a lot of different ways to fund them, because they typically aren't treatment. As you know, they're everything essentially else in a person's life, which is critically important outside of the treatment to support them, access to jobs, reentry from recovery, jail, rehabilitation, harm reduction. They do all sorts of different things. So I do think that that is an area that is recognized, and I think the mechanisms for supporting both how and how much are continuing to be evaluated. There is some support, but I agree. I think there needs to be more outside of sort of coming up with their own dollars from local counties or other just sort of private donations, which is how a lot of them operate. Or grants.
You see, it becomes like a best practice for us now. We partnered with Council of Southeastern Pennsylvania, which runs the operation we call PROACT. And you can't have true recovery. Recovery is not about treatment only. It's about the holistic approach towards recovery. And in a treatment court, I think it's a best practice to begin to partner with these types of organizations. Again, great area for the opioid settlement funds. These areas where, you know, I think Representative Gregory talked about, it is an important component. I mean, I'm not in the fellowship. But I see results over 18 years. Those that surround themselves with recovery services and support, it's the 5 years out. I can give you the 2 or 3 years out, but it's the 5 years out. And the more they have in terms of community recovery resources, the better we're going to do at this, pure and simple.
Thank you, Mr. Chairman.
Thank you, Representative Nelson. And we are running close to finishing on time, but I do want to ask a couple of questions, if you can keep your answers briefly. Ms. Maraglia, Marulia, I'm sorry, I mispronounced your name. I had it wrong, and I had it right, and I got it wrong again. I got to tell you, thank you, first off, for being here. Thank you for sharing your story. Your story is both inspirational and, quite frankly, it scares the hell out of me. I grew up in a middle-class family. My kids, I have a few of them, are growing up in a middle-class family. I'm not running for president, I promise. And today we've been talking a lot about treatment. I'm curious, what's your perspective on prevention? What can parents be doing to prevent their kids from going down that road?
So I said I was a mother when I started. I have a 16-year-old daughter at home, and you better believe I go through her cell phone every day. You need to know what your children are doing. You show me who your friends are, I will show you who you are. That is, because I also ran the juvenile unit when I was in the DA's office. So a lot of these times I meet the parents, and it's a no-brainer why we're in this situation. And I'm asking the courts if we can get independent living involved and get these kids out of the house, because sometimes their house is the problem. Sometimes it's not. So for the ones that maybe it's not, again, you have to know who your kids are hanging out with, what they're doing when they're not home, and it starts now as easy as a cell phone. When I was a kid, my parents would have had to come out physically looking for me in a car. We didn't have cell phones. You know, good luck finding me, even if you came out looking for me. Now, I can pick up my cell phone, press a button, and I know exactly where my daughter is. Might be creepy, and maybe some people think I'm a helicopter mom, but I know what she's doing at all times and who she's hanging out with. And that's the only way to prevent it, because it is in every school. It's everywhere you look. You know, and it may be as simple as the marijuana, but the marijuana is coming back with fentanyl in it. These kids are overdosing. I had kids in the ERs because they smoked pot. You know, that shouldn't be happening. They talked about it earlier, the cocaine. I haven't seen cocaine without fentanyl in it probably in 2 years now, every lab I get. We're having overdoses because people use cocaine and they die because they're not opiate addicts and there's fentanyl in it, so their body's not used to that. And that's what's happening now. So the fentanyl is just in every drug, and that is why you need to know exactly what your kids are doing and who they're hanging out with. And schools, of course, getting into schools. You know, I went into all the schools in Luzerne County and talked to the kids. We started with the 6th graders, and I would go to the high school too. I didn't, you know, do the elementary. I think that's a little, that's like the DARE program. There's other programs for that, of course. But I was going in to speak to the older kids where I was seeing the drugs in the schools and telling them exactly what's happening. You know, you think you're just smoking some pot with your buddies, and now we have kids in the emergency room. So educating the kids, which can only go so far because we know their brains aren't developed. They're in one ear, out the other. As soon as all their friends are doing it, most kids aren't going to say, oh, no, that assistant district attorney told me I shouldn't do that. Or, right, that's not going to happen. Peer pressure. They're probably going to do it. So knowing who your children are hanging out with, knowing the parents of the children your children are hanging out with, you have to be proactive as a parent. Absolutely, you have to.
Thank you. Thank you, Chairman Heffley. Thank you to my staff. I thought this hearing was exceptional, and the testifiers, thank you all for being here. Really just a professional, informative hearing, each and every one of you. I appreciate you being here. I'm going to hand it back over for some brief closing remarks to Chairman Heffley, and we'll go from there.
Thank you, Chairman Kale, and once again, thank your staff. Thank Anne Marie, Hap, and everybody else involved in putting together this panel. I think it was really informative. We look at a lot of programs that are successful, and how do we mimic them in other areas. Also, how do we address what's coming and getting that word out to the public. Probably could have had about another 30 questions here and a couple more hours, but I think this was a great informative meeting and really a point to step off and move forward with some initiatives. I know a few years ago we worked on the opioid task force, and there was 15 recommendations that came out of that task force, and most of them were either done through legislation or through regulatory changes, and it had significantly impacted. When people say, well, what can the legislature do about different things? And I think most telling fact in that whole process was the year after we implemented youth prescribing guidelines, youth prescribing of opioids went down by 50%. And that was just an incredible feat. And it shows legislatively, when we work together and we have hearings like this and we take that information back and develop policy to keep up with those trends. The problem is the trends keep changing. The traffickers are going to continue to traffic these drugs. And I think that's something we didn't touch on today, but it's something I think we need to look at. This isn't happening in a vacuum, right? The people that are trafficking these drugs, I think that's the next phase. But right now, I really want to thank you all for coming out today and sharing your wealth of knowledge with this committee.
Thank you, Mr. Chairman. And so often it seems like this issue is a abstract, impossible issue for us to really tackle, and it's just out there, and it's something we're going to have to deal with. To hear from people that are on the ground actually making a difference and getting information on how we can be helpful, making a difference with you and others like you across the Commonwealth is very helpful for us. So we're going to keep this conversation going, and there's a lot of work for us to do here to assist you all in the good work that you're doing. So I appreciate you being here and telling us about it. The next policy committee hearing takes place tomorrow, Tuesday, September 24th in Boiling Springs. We'll be discussing how to advance pro-business, pro-jobs, and pro-family policies that will strengthen Pennsylvania's future. Until then, this committee is adjourned. Thank you all for being here.